Fortunately, we have
you
got
have the nice picture.
three young stars of the world tonight in Bangladesh. Three youngsters.
Well, it's a
So
pleasure to be here with
if you
everybody.
give permission, we can start, Ike.
Yeah.
Great.
We are live on YouTube, so we can start, and it's 8.
Okay. So our program is also being telecast in YouTube and many Facebooks. And usually we have 2,000 to 3,000 participants in most of the webinars. So hopefully this time also will be like this. Thank you very much. So let me start. Assalamu alaikum and good evening, everyone. On behalf of Bangladesh Glaucoma Society, I am Dr. Nazrul Islam, welcoming you all in this webinar tonight on glaucoma surgery update. We are very happy that tonight we have very internationally renowned 3 faculties will talk in this webinar. Let me introduce our faculties: Professor Aik Ahmed from Canada, Professor Tanuj Dada from India, Associate Professor Dr. Shilbin Singh from Singapore. Very good welcome, all of you in Bangladesh to this webinar.
Thank you.
We have distinguished panelists in this webinar: Professor Sheikh Mannaf, Professor Arif Mia, Professor Mizanur Rahman, and Professor Zakia Sultana Shahid. Welcome all of you in this webinar. I hope it will be a brilliant webinar, an exciting webinar for us tonight. Myself, Dr. Ishtiaq Anwar, and Dr. Salma Parveen will moderate the session. First of all, I would request Dr. Salma Parveen to introduce our panelists, please.
Okay, thank you, sir. Welcome, everybody. I'd like to introduce first our distinguished panelists. Number 1 panelist is Professor Sheikh Mannaf. He's a senior consultant and managing director of a very popular and leading hospital, Harunai Foundation and Hospital, and former head of the ophthalmology in Bardem, past president Bangladesh Glaucoma Society, and he is advisor of Bangladesh Glaucoma Society. Professor Mohammad Arif Mia, he's senior consultant of one of the leading hospital. He was a former director, National Institute of Ophthalmology and Hospital, and past president Bangladesh Glaucoma Society, and he is now advisor of Bangladesh Glaucoma Society. Our next panelist is Professor Mohammad Mizanur Rahman. He is currently the president of Bangladesh Glaucoma Society and professor and head of the Department of Ophthalmology in a leading medical college. Next is Professor Zakia Sultana Shahid. She is a consultant of one of the leading hospital and past Secretary General of Bangladesh Glaucoma Society. And our moderator, Professor M. Nazrul Islam, is very well known glaucoma specialist and is chairman glaucoma faculty of Bangladesh Eye Hospital Institute. He was past president of Bangladesh Glaucoma Society. He is current president of Bangladesh Society of Cataract and Refractive Surgeons and on board director of Asia Pacific Glaucoma Society. And myself, Dr. Salma Parveen, currently the Secretary General of Bangladesh Society, Glaucoma Society. So this is the introduction of our distinguished panelists. Thank you.
Thank you, Dr. Salma. Now, without delay, let us start our webinar. Let me share my slide. Okay. So first of all, I'd like to acknowledge that we have hundreds of attendees and participants from 19 countries, most of them from Bangladesh and India, but also from many countries of the world. I'd like to thank and welcome all the participants to this webinar. And I would also like to request you, please put your comment question to the question box, and we'll try, our panelists and speakers will try to answer your questions. Thank you very much. They are our speaker tonight. Let me introduce the first speaker, Professor Tanuj Dada. I know him for a long time, a very gentle gentleman, good ophthalmologist, good teacher, good researcher, and great writer also, great author also. He is working in the RP Center for Ophthalmic Science, AIMS, in New Delhi. He is the current Secretary General of the International Society of Glaucoma Surgery. Professor Tanuj is the Senior Chair of the Associate Advisory Board of the World Glaucoma Association. He is also on the Board of Directors of the Asia Pacific Glaucoma Society. And personally, I know he's contributing a lot to this society. He is the Chief Editor of the Journal of Current Glaucoma Practice. He is the Associate Editor of the Journal of Glaucoma. And as I told, he has more than 300 research publications in the peer-reviewed index journals. He has 5 textbooks on glaucoma, and I believe many of us here has read his books, including myself. He has trained many of us from Bangladesh and other countries. Thank you very much, Dr. Tanuj, and the floor is for you. Over to Dr. Tanuj, please. Let me stop my share.
So thank you very much, Professor Nazrul Islam. It is really nice of you to give this hearty introduction, and I really want to thank you and the members of the Bangladesh Ophthalmic Society for this kind invitation, and hats off to you for arranging all these webinars. And you have been a very hardworking person, and I know you for a very long time, and you have worked tirelessly for the field of glaucoma worldwide. So today, the topic I am going to speak on is trabeculectomy, which is the current gold standard for glaucoma surgery, especially in developing countries. I have no financial disclosures. Now, if you see the World Glaucoma Association consensus statement, trabeculectomy is currently the procedure of choice for glaucoma in previously unoperated eyes. And the main reason is that it has a better and a sustained IOP lowering as compared to other types of glaucoma surgeries. But there is an inherent paradox in trabeculectomy surgery. If you use antifibrotics to inhibit the repair, you may end up with hypotony and infection. And if you let the bleb heal on its own, you can end up with scarring and bleb failure. So there is a critical balance, and what is very important in addition to doing surgery is to modulate wound healing to enhance success and reduce the risk of complications. And you must have an early recognition and treatment of complications, otherwise you can end up with sight-threatening complications. So why do I say that trabeculectomy is a good procedure? If you see the long-term outcome, this study from Peter Watson's group, you can see that at 20 years, there is a 90% survival of trabeculectomy with 2 topical medicines. And this gives you an idea that this procedure can have a IOP lowering over a long term, over decades, as compared to other types of glaucoma surgeries. And if you evaluate patients who have undergone trabeculectomy with mitomycin C, you can see at 9 years follow-up, nearly 3/4 of the patients can have a good target IOP of less than 18 millimeters of mercury. Now, the important point to remember is, you can see in this study, nearly 1 decade of follow-up, mitomycin C was used 0.2 milligram per ml for 2 minutes. So a lower dose of mitomycin C, and with that, the incidence of bleb-related complications is much less. So the current issue is, how can we improve the outcomes of trabeculectomy surgery? So I'll start with something I tell my residents when they are training, that you must do a prayer before trabeculectomy, because you are interfering with Mother Nature, and the outcome, you may be a very good surgeon, but the outcome depends on how Mother Nature treats the fibrosis. You have a heavy fibrosis, good surgery can end in failure. If you have less fibrosis, you can have a bleb which functions very long. So that is something that is not in your hands, that is in the hands of Almighty. So the first important issue is, in trabeculectomy, you should learn to avoid high risk situations which may end up in failure. So the first principle is to check the conjunctiva. So what I normally do is I make the patient slit on the slit lamp and just move the upper lid and see if the conjunctiva is mobile or no. That is the most important test before a trabeculectomy. And you have to especially rule out the situations where you can end up in failure. That includes patients of blepharitis, mebomitis, NLD block, and contact lens users. These are the patients in which there is high risk of blebitis and subsequent endophthalmitis. In addition, patients who have any form of conjunctival scarring, any previous surgery, any ocular surface disease, and if you are using a subconjunctival anesthesia in the area of the bleb, these are all risk factors for failure of trabeculectomy, and you have to rule these out before you take a decision to perform trabeculectomy in a patient. Now, before a patient is taken to the OR, most of the patients are on multiple glaucoma medicines that leads to subconjunctival inflammation. So before you do trabeculectomy surgery, it is mandatory that you quieten the conjunctiva by giving a preoperative course of steroids for 2 to 4 weeks. So you can see in this study, the success rate of trabeculectomy was much higher when preoperative steroids were given as compared to patients who just went ahead with surgery without steroids. So the first principle, always prepare your patients by giving pre-operative steroids for 2 weeks and check the intraocular pressure. It should not rise because many of these patients may be steroid responders. The second important principle is when you do trabeculectomy, you should avoid touching the superior rectus. So in this study done from the UK, you can see the poor outcomes were associated with 3 conditions: a superior rectus traction suture, diabetes, and non-specialist surgeons. So you have to have a very good training. And if you touch the superior rectus, you injure the muscle sheath, and that can lead to fibroblast proliferation over the area of the bleb and lead to bleb failure. In addition, if you handle the superior rectus, you can have ptosis, and that is a very serious cosmetic complication that you should avoid. 12% in this study. So don't touch the superior rectus when you're doing a trabeculectomy. Then the third principle is if you are using subconjunctival anesthesia, avoid the injection in the area of the proposed trabeculectomy bleb. 2 reasons. One is the subconjunctival anesthesia can promote fibrosis. And secondly, if you get a hemorrhage in the area of the proposed bleb, your trabeculectomy is going to fail. And the second important principle while doing trabeculectomy is always make an anterior ostium. That means that the patient should not have an opening which is posterior that leads to a lot of complications. Always make an anterior opening. So this is a short video. I'm just showing you. You make a lamellar scleral flap 50% depth with a crescent knife and cut open both sides. And then you expose this critical area. So you have 3 zones. You have this white zone, which is the sclera. You have the transition bluish zone that contains the trabecular meshwork Schlemm's canal. And then you have the clear cornea. If you want to do a safeguard, a good trabeculectomy, always try to enter the area of the clear cornea. If you go posterior, you can hit the zonules, you can hit the ciliary body. So always try to enter in the clear cornea. That is what I'm saying. You put in an air bubble before entry, put in a pre-placed suture, and then make a guarded entry. You are cutting with a Vanna scissor. Now the important thing here to understand is whenever you make an ostium, you must have a guard of scleral tissue on both sides. So if it is a 4 millimeter flap, 1.5 millimeter tissue should be there on both sides. That prevents the shallowing of the anterior chamber in the post-operative period due to excess drainage. So you make a broad basal iridectomy, and then you close the flap. The pre-placed suture is already present. Now, what can go wrong at this step? This is a patient, of course, this is a congenital glaucoma. I have done the trabeculotomy, and now I am doing the trabeculectomy. And once I made the ostium, I could see a bleb of vitreous coming. So this is a vitreous loss that can occur while doing trabeclectomy, and the main safeguard is always go anterior into the clear cornea. If you are posterior, you can get this vitreous loss, which is quite a serious complication you can face if you are posterior in your incision. The other issues which you can use in trabeclectomy is to use a AC maintainer. It helps you to maintain the chamber during surgery, and use releasable or adjustable sutures. And if you have a high risk situation in which patient has less than 10-degree field, you can leave some amount of sodium hyaluronate in the anterior chamber to prevent a shallow anterior chamber on the first post-operative day. So this is a patient of Sturge-Weber where there is a high risk of choroidal effusion. And in this, the additional step is that we are using an AC maintainer. So that maintains the intraocular pressure, and also any inflammatory mediators and blood, it will egress due to the AC maintainer is on. So they'll be flushing out of all the inflammatory mediators and any hyphema which develops during surgery. Once you're making the ostium, you close the drainage and then again you put it on, and you can judge the titration of your filtration by the AC maintainer. And another thing which we modified was to do a deep sclerectomy along with trabeclectomy. So this is known as an augmented trabeclectomy. The basic purpose is to create an intrascleral lake. So this is our technique that we reported, trabeclectomy extra. So after making the laminar scleral flap, we are making a deep scleral pocket. So in this crater, you have aqueous, and then prevents adhesion between the two flaps. So after you have made the laminar scleral incision, you make a deep scleral pocket like a deep sclerectomy. It should not extend anteriorly. And then you go ahead with the routine surgery. And when you close this, you can have an intrascleral aqueous lake. So the advantage is you are draining into subconjunctival space. In addition, you are having an intrascleral lake which prevents the fibrosis between the two flaps. And if you are deep enough, you also have some subchoroidal space, suprachoroidal drainage available with this technique of trabeclectomy combined with deep sclerectomy. Now, question commonly asked is, what should be the mitomycin C dosage? So for primary surgery, you should not exceed more than 0.2 milligram per ml. And if you're doing a resurgery, it can go to 0.4. And the duration should be 2 to 3 minutes. And the application should be a very broad subconjunctival area. And another modification you can do is, in addition to subconjunctival mitomycin C, if you apply intrascleral mitomycin C, there is some evidence that that prevents fibrosis, and actually the success rate is better of intrascleral application as compared to subconjunctival mitomycin C application. There is a lot of interest in the use of anti-VEGF agents in trabeclectomy, but I want to make it clear, there is no benefit of adding subconjunctival anti-VEGF in trabeclectomy. There is no difference in the outcome. And so there is no point in unnecessarily raising the cost of surgery. Meta-analysis has shown that the anti-VEGF agents did not show any benefit as compared to using mitomycin C. So we should not be using anti-VEGF agents in trabeclectomy unnecessarily. Another controversy is, should we use Ologen implants? So we tried at our center the Ologen implants, but if you compare the Ologen alone versus mitomycin C, very poor outcome of the Ologen implant as compared to mitomycin C alone. And this is from the Singapore group. You can see very poor outcomes of the intraocular pressure reduction. Ologen group 2.18 and mitomycin C 8. So Ologen alone gives very poor outcomes as compared to mitomycin C, and that is due to an inherent fibrosis that occurs within the implant. And again, you can see outcome of mitomycin C versus Ologen implant. So the 93% success with mitomycin C as compared to 40% with Ologen alone. And what we tried to do was use Ologen along with mitomycin C to see whether it enhances success. And this was our randomized controlled trial, and you can see there was no benefit of adding Ologen implant to mitomycin C. In fact, at 12 months follow-up, we had a worse outcome in the Ologen mitomycin C group. So currently we have stopped using the Ologen implant. We found it does not enhance the success of surgery either alone or in combination with mitomycin C. The other important question to understand is that should we do a trabeculectomy before or after lens extraction? So this is a question that is commonly asked. If patient has both cataract and glaucoma, which one should you do first? So you have to understand that whenever you do cataract surgery in a patient who has a filtering bleb, the cataract surgery can compromise the IOP control even if you're doing it at a temporal location because of the inherent inflammation that leads to subsequent fibrosis. So cataract surgery definitely reduces the function of the filtering bleb due to upregulation of the fibrogenic cytokines. So it is always better that if you have a patient of cataract and glaucoma, you do phacoemulsification first, followed by trabeculectomy, rather than the option of trabeculectomy first, followed by phacoemulsification. And in this study from Dr. Croston's group in Australia, they found that the sequence of phaco followed by trabeculectomy has much better outcome as compared to the sequence of trab followed by trabeculectomy, followed by phacoemulsification. So always first take out the cataractic lens and then subsequently do trabeculectomy. So once you have done surgery, you must give steroids for at least 8 to 12 weeks after surgery. Don't be in a hurry to stop steroids. And if your bleb fails, this is a technique that we first published, the OCT guided bleb needling. So you have to needle the bleb if the bleb is failing. However, if you do needling, the long-term outcome is not good. You can see at 3 years, most of the blebs had again failed. There was a rise in IOP. So a short-term measure may be there with bleb needling, but long-term outcome of bleb needling is not good. So what is the alternative if bleb needling does not work and your bleb is failing? So recent studies have shown that you can do a posterior revision of the failing bleb. That means you again open the bleb, put in mitomycin C, and again open the ostium. So revision trabeculectomy gives much better outcomes as compared to the needling. This is a study from the US, small incision revision of trabeculectomy. So it gave a substantial IOP lowering as compared to studies on needling. The IOP was sustained at 5 years with a success rate of nearly 70%, IOP less than 18. And the most important thing after you have done trabeculectomy with mitomycin C is to prevent bleb complications. The most problematic one is blebitis and endophthalmitis. So whenever you do a trabeculectomy, you should remember that the bleb-related infections can occur at any time during the postoperative period. If you have a late bleb leak or a patient of blepharitis or somebody using punctal plugs, juvenile and pigmentary glaucoma, these are conditions in which there is high risk of late bleb infection. So if you have a patient of bleb leak, they must be managed immediately with surgical means because these are the patients that will go into blebitis and endophthalmitis. So if you get a patient of early bleb leak, that means bleb is leaking within 6 weeks, you can give a short course of oral doxycycline along with a contact lens or banding. So oral doxycycline is effective, it inhibits collagenases, and it may help to mitigate the early bleb leak. This is one of the patients who has already had a bleb repair and again has a small leakage referred to us with hypotony maculopathy. And we gave the patient a 2 weeks course of oral doxycycline. This is just, you can see in the center that there is a bleb leakage here, and this is after bleb repair. And we gave the patient 2 weeks of doxycycline therapy, and the leak went off, healed very well. The hypotony reversed without any surgical intervention. However, once you get a late bleb leak that is due to a dysfunctional epithelium, then you must do a epithelial exchange. That means this bleb has got a dysfunctional epithelium that has to be covered by a healthy epithelium. So this is a very simple procedure. Patient has a late bleb leak or a hypotony. You just take off the dysfunctional epithelium and cut the conjunctiva on either side. So the epithelium has been removed after staining with Typen blue, and then you just cut the conjunctiva on the surrounding and overlay this ischemic bleb with healthy conjunctiva. So this is a very simple procedure, just the epithelial exchange, and you can get a very good postoperative outcome with a very minimal of surgical requirements. This is a patient of hypotony maculopathy, 28-year-old lady with juvenile glaucoma. So here I'm showing a technique, very simple technique. This patient has got a ischemic bleb and there is also small area of scleral necrosis. So what I'm doing is called Momini's repair. I have raised a lamellar scleral flap and that is deflected anteriorly to close this area of the scleral necrosis. So now I reflect the flap anteriorly and then raise a pedicle flap from the adjacent conjunctiva to close this defect. So a simple Momini's procedure with the rotational pedicle flap, and you can get a good post-operative result, and you don't require any eye bank sclera, and you can see preoperative bleb and the post-operative outcome with a healthy overlay of conjunctiva. So important take-home messages for trabeculectomy: always do a preoperative checklist and rule out the causes of failure or the infection, especially blepharitis. You must give preoperative topical steroids for 2 weeks prior to surgery. Do not give anesthesia in the proposed bleb area. Use a low dose of mitomycin C for primary surgery. Never exceed more than 0.2 milligram per ml for 3 minutes. In advanced glaucoma, try to use a AC maintainer and always use releasable or adjustable sutures. What I showed you, you can make a deep scleral pocket to augment the surgery by indicating fibrosis. Post-operative steroids must be given at least 8 to 12 weeks. And whenever in the post-operative period you get a wound leak, that has to be managed aggressively with the surgical maneuvers. So trabeculectomy is a high yield, high risk, high maintenance surgery. You should do your best and pray for the rest. So I'll close here. Thank you very much for your kind attention.
Thank you so much, Tanuj, for your fascinating presentation on trabeculectomy. Would you please stop share? Well, it was really fantastic. You have covered trabeculectomy and most of the complications also, management also. Very nice. Thank you so much.
Thank you.
And you know, in Bangladesh, India, in developing country, our glaucoma surgery is mostly trabeculectomy. So it is really beneficial for us to learn. Beautiful. I have learned a lot from your lecture.
Thank you.
We have few questions before Dr. Aik, and then we'll have all presentation, then we'll take question from other attendees.
Sure.
I'll go to the panelist first. Professor Sheikh Mannaf, would you please comment on the lecture of Dr. Tanuj? Professor Mannaf is a very good trabeculectomy surgeon, very good filtering surgeon. He does very good trabeculectomy. Professor Mannaf, please.
Okay, thank you. Thank you, Professor Nazrul. Thank you, Professor Tanuj Dada, for presenting a nice presentation with all types of management and also the management of complications. I have been doing this trabeculectomy since 1984. And I am very much comfortable with the trabeculectomy still today. I am not doing any other surgery other than trabeculectomy nowadays. And sometimes I have some lot of problems as well and difficulties. And I want to have a suggestion from you that what will you do for a case, an woman one-eyed, 55 years, pseudophakic, having failed trabeculectomy with a very tubular visual field. What is your suggestion to do for this lady?
So I think we have now a lot of additional options available. So first thing is, if the patient has had a failed trabectectomy, you try to establish what is the cause of failure. And if the trabectectomy is not very old, you can try a posterior revision. You open up the conjunctiva, dissect the scar tissue, insert mitomycin C and try to reopen the ostium. That is one option. The second option is if the patient is not willing for a subsequent major surgery, then maybe you can try a new modalities like micropulse laser or a limited diode laser if the patient is not willing for surgery. The third option is to do a second trabectectomy at a different site. So once one side the surgery has failed, if you have a different site available on the temporal or supratemporal or supranasal side, you can do a second trabectectomy, and in here use a higher dose of mitomycin C. And because patient has got tubular vision, you must use AC maintainer, try not to lose the anterior chamber, and use releasable suture so that patient does not have a post-operative shallowing of the anterior chamber. That is my suggestion.
Thank
Okay,
you.
thank you very much for your best suggestions. I think these are the best suggestions and options for this type of complications. Thank you very much,
Thank you.
Professor.
Thank you.
Okay.
Thank you very much. Now, when I request Professor Arif Mia to have you comment on this topic.
Thank you, Professor Tonus Dada, for your excellent deliberations on gold standard trabeculectomy, which is mostly done for glaucoma patients throughout the world. Most important, there was a on trabeculectomy use antimetabolites, mitomycin C, 5-FU, etc. But they has got pain with gain, gain with pain. So blebitis, endophthalmitis may happen. So can we think any other agent which can cause less damage to the tissue and less toxic? If any agent nowadays available, can you think anyone? This is one. Should we use MMC in all cases routinely or in selective cases? And my last question is, do you think anti-VEGF, you have said anti-VEGF subconjunctival is not effective, but in some literature they have said that it can be used intracamerally and with effect and long-lasting effect is good. I want your opinion. Thank you.
Okay, thank you very much, sir. So I think currently we don't have alternative because you are doing a surgery and you want the surgery to last a lifetime, 20 to 40 years. So currently we don't have alternative to mitomycin C. The problem is that people are using very high dose like 0.4 milligram for 4 to 5 minutes. That should not be done. You should assess the patient, see how thick the conjunctiva and tenon is, what is the risk factor for failure, and then titrate dosage of mitomycin C. If you use 0.1 to 0.2 milligram per ml for 2 to 3 minutes, the complications significantly go down. That is number one. Number two is if you have post-operative scarring, then you can use 5-fluorouracil. Be very careful that it should not come in touch with the corneal epithelium because it can be very toxic. And the third issue, the VEGF, a lot of people have used intracameral as well as subconjunctival. But if you see all the studies in literature, the anti-VEGF has a short-term effect. You want inhibition of fibrosis to last months and years. So that is why these agents are not effective. They are to be used intracamerally or intravitreally only if the patient has a neovascular glaucoma and you are going to operate trabectectomy. They are not recommended for routine trabectectomy surgery. Thank you.
Thank you. I have a question to Dr. Aik here. Dr. Aik, you have shown in your YouTube video the subconjunctival low dose MMC is effective before trabeculectomy. And after encouraging from your video, I am using for last 2 years this subconjunctival low dose or low diluted dose of MMC. So question to Dr. Tonus, you have shown the SPONS MMC. And what is your opinion regarding this subconjunctival diluted MMC before trabeculectomy? Then I'll come to Dr. Aik.
Yes, I think it is a very good option. I have now started using subconjunctival mitomycin C low dose. So it's a good option. You can give the injection and then dissect the tissue and wait for some time, it gives quite a good result.
Okay, thank you. And Dr. I, could you please comment on this issue, particular issue?
Thank you very much, Tanuj. I enjoyed your speech and always good data-driven evidence and reflection. So thank you. The use of mitomycin injections as opposed to sponges has been around for many years, probably 15 years as far as I know, and has been used. We do need more data. I will say this: we need more evidence properly to compare them in a properly done study. Now, there is some evidence and there's some studies, as you will see, and most of them show that the results are fairly similar, maybe less encapsulation, perhaps a more posterior distribution of flow because of the injection. So I do like it. I typically use, not more than 0.1 cc, however, because doing more than this, we get a very large exposure and we don't need it to go into the adjacent quadrants. I have moved to actually doing my injection after I open the conjunctiva and tenons as opposed to before. And why do I do this? Is because I like to get the dissection of tenons done first, and this allows for a clean dissection. If we inject it before, then the tenons gets hydrated, it becomes more splintered. And so this is my own preference. But I think, I mean, either option is okay. I don't think one option is bad or the other. This reduces the risk of losing a sponge, number one. And number two, it's really actually, if you think about it, a more accurate dosing rather than, relying on sponge characteristics and absorption. And I don't think it's dangerous, I'll tell you this. However, like any mitomycin, you can still get complications because it is mitomycin and it is a partial thickness filter.
True.
Thank you, Dr. Aik. Dr. Shelvin, do you have any opinion regarding the MMC used in trabeculectomy?
Well, I do agree with Ike that injections sometimes give it a more posterior and more diffuse location as well. But to put it on sponges, I think we'd be very careful to avoid the edges of the conjunctiva, as well as to make sure that you irrigate the mitomycin C away completely so as to avoid the complications of mitomycin C.
Thank you. Dr. Aik, what I do, I take 0.1 ml MMC, 0.3%, and I add 0.0 ml lidocaine with it, and I put under conjunctiva. Is it okay? Is any problem?
So we did a study because lidocaine and its pH, we were worried that lidocaine may potentially reduce the effectiveness of mitomycin. The answer is it does not affect the mitomycin power. So you can use this no problem if you wish to do that. Not a problem. It's fine. Of course, remember, now you've diluted your concentration. So in effect, you're using a lower concentration. We have to be mindful of this depending on the patient. As Tanu said, if it's low risk, you can use I typically use 0.2 milligrams per cc, non-diluted, but I do go up to 0.4 if it's a reoperation or a darker patient or a younger patient. And if you dilute it with lidocaine, then you have a lower concentration. So just be mindful of this. And for that reason, I'll be honest, I don't typically dilute it myself. I just use the pure stuff, and I can do some top-up lidocaine if I need to, in addition, if I need to.
Thank you. Dr. Vanita Patok from India asked the same question. I think she got the answer. Dr. Tonus, you have many questions, but I think after all presentation, we'll come to you again.
Yeah, just one point, Dr. Nazrul, just one point regarding the sponges. We have had occasions where the sponge has been left inside.
Yes.
So that is very disastrous complication.
Yes.
So just one tip.
I had only once.
You can stain the sponges with trypan blue. Yes. Before putting the sponge, just stain with trypan blue so that it is visible when you take it out. Because I have had residents who have left the sponge, it's not visible. So if you stain the sponge and then put it, then you cannot falter. It will be visible and you will remove it. Thank you.
Thank you. Let me go to the second speaker. Share. Sorry. Let me share this slide. Dr. I, can you see? You have so many fans in Bangladesh. So many fans in Bangladesh. And really, we are very happy to found you in Bangladesh in a webinar. Really, we are so much happy. Thank you so much. Actually, Dr. Aik is one of the 3 influential and famous ophthalmologists of the world. It was published in the Journal of the News Ophthalmologist, in the magazine. And I've seen such a talented young ophthalmologist I've not seen in my life. He's so talented. He does so complicated, so complex surgery, especially cataract and glaucoma. Really, I learned many things from your YouTube videos. You are a great teacher. Thank you so much. And of course, he is now working as a clinical professor in the University of Utah in Canada. He is director of the Glaucoma and Advanced Anterior Segment Surgery Fellowship Program in the University of Toronto. He's the research director in the Kensington Eye Institute. He is the medical director of the Prism Eye Institute. He has given over 1,000, wow, 1,000 scientific presentations so far in the world, including 40 visiting professors' lectures. He has published 150 peer-reviewed papers. He is in the editorial board of many important journals, like the Journal of Glaucoma, Canadian Journal of Ophthalmology, EyeNet, Ocular Surgery News, Cataract and Refractive Surgery Today. He has also published books on glaucoma and intraocular lens. He has so many credentials. How many I tell you? He was he was one of the top 40 before 40. He was the Binkhorst winner, medal winner in ASCRS. He had video award in ESCRS and got the best of show award in the American Academy of Ophthalmology. And lastly, mix. He is the pioneer and actually nurturing the mix from the beginning. So makes it to this stage, a lot of contribution for you, we know. Thank you so much, Aik. The floor is for you.
Nazrul Islam, thank you so much for such a kind introduction. You have to send me your that picture of all of us because definitely. I really miss those times. Those are great times, and really you're very kind with your introduction. But really, like all of you, I am here. I love what I do, and I think if you have love and passion for what you do, then I think it maybe helps you to do a good job. And I can be honest with you, anything that I have been able to do is nothing special. It's really just working and enjoying it, and a privilege. It's really a privilege. And I will say that I am privileged because in my center, in my country, we have access to so many different technologies, and we have a public healthcare system, which is very good. Patients come present to us earlier in disease. On the other hand, I have tremendous respect for my colleagues around the world, like in Bangladesh, which is more developing in its nature, where it is more challenging to take care of patients, especially chronic disease like glaucoma. So I actually have more respect for you as far as the challenges you have and how well you've been able to do to save patients' vision, despite the hardships and the challenges that you face, as opposed to where I am from. Now, I am originally, my parents are from India, and so from Bihar, and so for me, Bangladesh is close to my heart. And I hope one day, inshallah, to visit. And I want to wish assalamu alaikum to everybody as well here from Canada. And it's a pleasure to be here with Tanuj and Chalvin, two incredible people who share so much and have such great knowledge and great people. I mean, I can't tell you how the beauty of medicine is with learning to meet great people. That to me is the most rewarding. Forget about the knowledge even. It's the great people who inspire you, which I hope this is mainly about. So I just wasted 2 minutes of my talk. I apologize, but I have been asked to speak about MIGS and getting started in the developing world, which I will say is a little bit of a challenge. These are my disclosures, and I do have a lot of different companies I work with. They're conflict of interest. It can create a bias. I will try to make sure I will try to keep things, as bias-free as possible, but that's always a potential challenge here. And I want to just start off just remembering that why we are here, in that we are not just about IOP and about medications and visual fields. We are taking care of people who are putting drugs in their eyes or who are facing surgery and have fears and concerns and quality of life issues. And we know that these issues are not small for many patients. And although for us, it's worth the price of saving vision, for our patients, these are everyday, daily problems that occur that affect their quality of life, how they live their life, how they go to work, how they interact with their societies. And this has led to reduction in adherence, which is recently shown in the SIGIS study, that when people don't take their medications, they get worse. And at the end of the day, it costs the society more money to take care of these patients when patients don't take their drops and they get worse. And that is the problem. And that's why we do surgery. And we have very, very powerful surgeries. As Tanuj has mentioned, trabeculectomy is the gold standard and is the most powerful surgery. And we know its role. However, we also know that it's not something that most of us do for all our patients. Unlike cataract surgery, when there's a cataract, we do surgery. In glaucoma, we don't rush to surgery. We treat with drops and other things because we are scared of the complications of surgery. And of course, glaucoma is a different beast, and we worry about the bleb. Any surgery that creates a bleb will always be a potential ticking time bomb for long-term complications. We cannot ignore this, unfortunately, although I will say our trabeculectomy blebs have gotten better. No question they are safer to do, and Tanuj has mentioned this. And so we must, first of all, remember that when we talk about a surgery for glaucoma, let's not group all patients together. That's a mistake. Glaucoma patients are not the same. And yes, with people with more advanced disease who are progressing, we need to go to the bleb. But there's another group of patients that don't need a bleb right away that we think about newer surgical options. And this is where really the era of interventional glaucoma has come, where we are intervening early with surgery, but doing it safer and predictable and addressing adherence. And that's the premise of it. And we have options that I think are in this category, like laser trabeculoplasty, like drug delivery, like MIGS and microstenting, which I think are less invasive, but yet also are safer and also reduce the issues around adherence. What's interesting, what these studies are starting to show, that even when these procedures have the same pressure lowering as medications, there's something more than what topical drops can do. And I look, for example, to the SLT Light study, which basically showed patients with mild disease mostly and ocular hypertension who were treated. And as you can see here, eyes who had SLT versus medications, most of them had pressure that was controlled. But you see at the bottom that 11 patients in the medication group that were mild to moderate after 3 years or ocular hypertension required trabeculectomy, while 0 in the laser group, despite the pressures being the same in both groups. Just ask yourself, why is that for these early patients? 11 is not a lot of patients out of 500 patients, I agree. But 11 patients, we have changed their life now by creating a bleb. Phaco MIGS, phaco hydrous versus phaco alone, randomized study, very well done. And we look at the patients at 2 years, the pressures were very similar between the two populations, very similar. The medications were lower in the phaco hydrous group. And there were more patients who had no medications in the phaco hydrous, phaco MIGS versus phaco alone. And what is interesting, when we look at these patients 3 years later and even longer, we have less patients needing to go on to trabeculectomy, despite the fact that the IPs were the same. Now, again, ask yourself, why is that? And I think it has to do, again, with control of pressure without relying on drops. And this is one of the premises of MIGS. The problem is, with glaucoma surgery, we have safe procedures like MIGS, but we lose efficacy. And this is the challenge with procedure selection between all these procedures. We have many procedures now that are new: trabecular mesh for Schlemm's canal, supraciliary, subconjunctival, and we're going to focus on this area, which is the conventional outflow. And these procedures are procedures that are more modest in pressure lowering. They don't lower pressure like trabeculectomy. And I wouldn't even bother comparing it to trabeculectomy. Maybe compared to medications, which is more appropriate. And these are patients who are looking at in the mid-teens pressures. The goal is to reduce medications and possibly eliminate. For me, the ideal mixed patients are patients who are going to cataract surgery and have glaucoma. I don't like to do combination phaco traps. I believe phaco traps are not as successful as doing trabeculectomy alone. It'd be interesting to speak afterwards with my colleagues. But phaco traps don't do as well. There's more inflammation, more blood aqueous disruption, even over 4 months, than trabeculectomy alone. I'd rather separate them out. However, phaco MIGS often work synergistically together, and I like to combine it together as an opportunity either to do it before trabeculectomy or staged. The patient who is young, uncontrolled, juvenile glaucoma, with or without uveitis, these patients, for different reasons, respond quite well to MIGS, and I like to avoid trabeculectomy in these patients. And then there's older patients who are not severe, but they're having problems with their drops and they're not compliant and they have red eyes. that I think MIGS can serve as a reasonable option. Now, there's so many options out there for MIGS, and it's a very busy field.
This
Some of these
curved, flexible filament with an internal lumen.
and some
This
of these
filament can be used to
are
inject
less
viscoelastic
complicated.
or to...
But I will say that with these procedures, that there's a difference with the approach, the cost, and the complications. I will stick primarily to dealing with cutting procedures in this talk because I believe these are more adaptable to the developing world. However, there are stenting approaches and other more complex approaches as well. And I won't go through all the data, but I will say that these procedures in general, whether they're combined with phaco or standalone is more useful because we don't have the confounding of phaco. These patients lower pressure modestly. They lower pressures to mid-teens, but they're not to replace trabeculectomy. And I want to, again, caution us from, thinking of these procedures as procedures that replace trabeculectomy. It's not a competition. It's not a rivalry. This is something that can be used, again, prior to trabeculectomy into the right patient. Remember that what we're doing here. The goal is to overcome resistance at the TM. We bypass the TM. We dilate the canal in some cases, and we make an assumption here that the distal outflow system is intact. This distal outflow system of episcleral veins and aqueous veins we assume is intact, which isn't probably all the time the case. We also know that from the Semmes canal, which is a rudimentary vein, there are collector channels that come off the canal. These collector channels lead to venous vessels, and some of them are large aqueous veins. Some of them are more of a plexus. You can obviously imagine the resistance is much less in the aqueous veins than in the plexus. And so we prefer to place devices or make incisions in the canal in the area where the aqueous veins are. And here's an example from Asher's work back in the 40s of showing this aqueous vein. It takes an understanding of distal outflow anatomy, which is something most people don't take the time to do, understand the implications of MIGS surgeries. And most of these veins are in the infranasal quadrant. Remember that. If we have to place or make an otomy or make an incision or goniotomy, it's preferable to do it in the infranasal inferior quadrant in that sense, in some ways. We also know that we don't necessarily need to make a 360-degree otomy because resistance plateaus after about 4 clock hours of opening up the canal. This is because of the distal outflow resistance that's present. And once you get past 4 clock hours, we don't necessarily find more drop. Remember this point. And so, for example, if I'm doing a trabeculotomy ab interno, I typically only do 180 degrees for most patients, except for pediatric congenital glaucoma, for example. And you can see what we've done is here, we're trying to get into the inferior quadrant, and I typically move 180 degrees, superiorly in many cases, but at least try to get something in the infranasal quadrant. When I do 180 degrees, I don't just do an inferior goniotomy because sometimes you get bleeding and the blood settles inferiorly, and this can block the trabeculotomy. So I think it's important to do it more nasally, infranasally, and even superiorly. And this is a consideration of where do you do your trabeculotomy. Just to show an example, this is using ab internal canalplasty using a microcatheter. This certainly makes it easier to do, but I'm just going to show this procedure here just to show the steps of the procedure. In this case, we're making a small incision, in this case in the infranasal quadrant to provide good access. The incision is very important for this catheter, or suture if we use a suture. MVR blade or a 27 or 25 gauge needle is used to do the goniotomy. Now, one tip, make sure we fill the eye with good viscoelastic to keep the pressure high, because otherwise we get blood reflux, which can affect our view. The goniostomy is very important, visualization is important, and there you see the goniotomy made with the use of the MVR blade. Push down the posterior lip, and this just allows you to see the scleral spur and the opening, fish mouthing of the canal. Now we use a microforceps. Now this is something that is important to have, is a microforceps. You can use it from the vitreoretinal surgeons, or you can have a specially designed microtire, which I'm showing you here. This is from MST. And we basically push it forward. Now this is of course helpful to have this red lit beacon showing me where I am. And you can see in this case, it travels around 360 degrees nicely. I can also use it to inject viscoelastic, by the way, as well. But we don't always get around 360. Typically after 180 degrees, we get resistance. And sometimes we cannot cannulate all the way around for many different reasons, mostly because we are probably caught and stuck on a collector channel. And there we see the distal end coming out of the goniotomy that's made. And then we can grab the distal end and pull on the proximal side to basically do, in this case, which is basically a 2-year-old, 3-year-old patient with congenital glaucoma, juvenile onset glaucoma, in this case actually. And you can see the otomy made. You can see the leaflets of the trabecular meshwork opened up. And we have now eliminated the resistance in these cases, which we know in congenital glaucoma and juvenile glaucoma, which I believe is a spectrum of the similar genetic issues that can occur in some cases, where the trabecular meshwork is dysfunctional and anomalous. And we typically like to leave some viscoelastic in the eye at the end, about 1/3 of the anterior chamber, filled with viscoelastic to prevent post-op hyphema. Now, in the developing world, this can be done with just a few dollars, using an MVR blade or a 27 or 25 gauge needle, 5-hole proline, a low temp cautery, and the one expense is using a micro tire, in this case from MST, or using a micro instrument from the retina colleagues as well. Here we're using the blunt tip of the low temp cautery to create a round nose tip of the 5-hole proline. That's all we do. This allows the suture to nicely pass smoothly in the canal. And then we basically make a decision. This decision is important. Place it in the right space to have the right trajectory to enter the TM. Have it in the eye before tilting the microscope. And then you can see we will basically, after tilting the microscope, make our trabeculotomy. In this case, you can see with a 25 gauge needle to swing left and right. Make sure this is long enough to allow the suture to be placed, and then bend the suture by basically pulling towards you to find the right angle, pushing against the TM, and push it forward. Usually it's about 40 short or 20 long pushes. And once we get past 180 degrees, we do get resistance. Now you can see, we cannot see the suture where it is. And there are situations where the suture may end up, for example, going suprachoroidal. If the patient has pain or bleeding in the eye, we should stop. This may indicate the suture is going more peripheral. And now we see the suture end in the anterior chamber. We grab the suture, it's very simple to do, and then pull the external side to create the 360-degree trabeculotomy, admixture trabeculotomy, or GAT, gonio-assisted transluminal trabeculotomy. There are other techniques like this technique, and this is basically what I typically do, which is basically, again, making a small goniotomy, passing the suture, in this case, 180 degrees. This is basically about 10 long pushes. And you know you're 180 degrees when you start to see the suture flex. Look at the flexion here. It's showing the bowing here because of resistance as we get past 180. At this point, we start pulling toward the center, and we call what we call walk the dog, meaning we basically grab the suture and pull the suture along the circumference of the angle. And this prevents the suture from coming out of the canal. We want to stay in the canal, right, to do the goniotomy. And then we regrasp, pulling, you can see here, and we do a nice 180 degrees, goniotomy that's done. And this is, for most adult glaucoma, this is what we typically do. This is another example just to show you with another mirror, another technique using the Omni system. Now, this is basically a built-in system which has a suture and has an injection port to allow us to do it. This is a phakic patient, lidocaine and myostats put in the eye for pupil constriction, click corner incision. And I'm using, in this case, a double mirror. This is actually using a double mirror without tilting the microscope, just to show you the canal with some areas of blood reflux, which probably indicate some areas of larger potential episcleral aqueous veins. We will basically, in this case, we're using this cannula. This is different than the suture. And what I'm going to want to show you is just to show you the passage of the cannula, because you don't always see this. Look at the suture moving around here, just to show you what's happening when we do an average trabeculotomy. Look at the suture pass around there. We can basically pass it all the way around. In this case, we can inject viscoelastic as well. And then we can retreat it back here. You can see the blood reflux now coming after we've cannulated the canal. This expands the canal as well and injects viscoelastic. And we can then do a goniotomy by pulling the suture as you saw there. This is a small goniotomy we did. And as expected, it's normal to get bleeding. I typically like to hold antiplatelets and hold anticoagulants to prevent excessive bleeding postoperatively. In this case, I went and did more treatment. In this case, you can see we're going 360 here. And you can see we're pulling the suture here to create, in this case, this was about 210 degrees of ab-internal trabeculotomy here. And you can see that passage there. And this is just to show post excision. Look at the trabecular meshwork flap folded down, which is where the TM has been opened, and you see the blood reflux from the collector system that is expected there as well. So just to finish off, I want to mention a couple of things. This technique is very dependent on you as a surgeon. And visualization is absolutely important to ensure. I like to use a Swan-Jacob lens most of the time, what we do for our juvenile or congenital glaucomas. I can hold my left hand or right hand and be very mindful for the view. For those that are starting off, this is what will happen. You have bubbles in the anterior chamber. You can see that the view is poor. There's stria on the cornea, the blood on the cornea from the incisions, blood in the eye. This is what we don't want to see, right? This is what happens at the beginning. So it does take time. The biggest challenge in learning MIGS is getting the right view. And these are our fellows and residents that are struggling sometimes to get the right view. Like, how can you put a suture in the canal when you can't even see it, right? And that's what's very important. Also be mindful of tilting the microscope enough. You can see before and after, we have a top-down view on the top because we're looking down onto the iris. We don't get a good view of the TM. Tilt the patient's head more, and now we get a more en face view of that. To prevent bleeding, it's nice to have a more reverse Trendelenburg, keep the head up to reduce the risk of bleeding. And just remember all the different things we need to do to tilt the microscope properly. This is eye stent here. Okay, but you can see we tilt the microscope about 40 degrees, 45 degrees. We turn the head.
Up my hand a little bit here, guys.
And this is topical anesthesia. The patient's head is tail is turned. We have a nice view of the trabecular meshwork. A very nice view, as we can see. And sometimes in a very lightly pigmented TM, of course, please do gonioscopy before you do the procedure in the office so you see the trabecular meshwork. Trypan blue can be used, and you can see how nicely it lights up the trabecular meshwork. This is probably good for when you're at the beginning stages. This is with eye stent to do that. So I want to just show that, and just to show, actually, sorry, one more thing.
The Cahook dual blade is a unique blade with two.
This is probably something that is maybe more available, the Cahook dual blade, which is two blades on either edge of this cutting instrument. This is like a knife, but it has two edges on it. And we basically place it in the trabecular meshwork to create this cut. Ideally, actually, not only doing a cut, but actually excising the trabecular meshwork. We usually start on one side and do the other. Typically, you get about 90 degrees of treatment here. And you can see the foot plate placed in the canal, sliding across. And we basically can then get a strip of the TM. And this is what you see after the procedure, the TM strip being removed. Remember, these patients are not trabeculectomy patients. They don't need lots of steroids. Treat them, yes, for the first week or two, but then taper them down because these patients can get steroid response. I put a little bit of viscoelastic in the end just to make sure if I do a trabeculotomy to prevent low pressures and bleeding. And sometimes we have to reintroduce medications if the pressure goes up in the first 2 weeks. But remember, when the steroids wash out, the new pressure baseline will often be achieved, and we can reduce the medications that are used. So those are some pearls for using MIGS in the developing world. And again, still a lot to learn from these procedures. Thank you very much.
Thank you so much, Ike. It was a wonderful presentation. And we have learned actually some kind of mix which is really helpful for the developing countries, like GATT, 360-degree ab-internal canaloplasty, Cahook dual blade. I think these are the possibilities you also find here. In Bangladesh, you know, Dr. Rashid Nizam from USA, he's from Bangladeshi. He came to Bangladesh and he trained some of us with Cahook dual blade. And we had the opportunity to do some 5-6 cases only, but it's not available here, so we don't get it. He also brought some eye stent. We did few only, but it's not available here. Then I think with 5-0-proline, GATT is possibility. I tried, but still I'm in the learning curve. It's not very easy, as you showed in your presentation. It's difficult. It takes some time to learn, really. So thank you very much. Now I would request our panelist, Professor Mizanur Rahman. Would you please comment? Professor Mizanur Rahman.
Yes, thank you, Professor Nuzul Islam. Actually, Dr. Aik Ahmed, he is the pioneer of this MIGS technique. And in our country, we have very little experience regarding this MIGS. Professor Nuzul Islam and I think few others trying to do this surgery. One thing I have an intention to know, what is the preferred option, Dr. Aik, you are using, whether suprachoroidal outflow or you are using the trabecular bypass stent? Which one you prefer, whether suprachoroidal or trabecular bypass? And another thing is that you are using stent, and what type of stent you are using? Which one you prefer, whether it is Hydras or Cyprus or Zelzen or this glucose eye stent? Which one is the best in your opinion? And the third thing is that whether you are using stent commonly or you are doing the trabecular surgery like trabectome or like the GATT, which one? So all these things we want to know, we want to share with you because we have a very little experience. And lastly, what is your suggestion for the developing countries regarding these MIGS? Which option we can try and how we can try? And which one is cost effective and how much effective for control of IOP? All these things, all these questions arise in my mind. So I think we'll be benefited from you. And let us give your opinion regarding these questions.
Yeah, I mean, there's so much to talk about, and I'm going to be very interested in Chelvin's opinion as well. She has so much experience as well. But I will just say a couple of things. First of all, suprachoroidal, CyPass is off the market. There were some problems with the cornea. I'm still evaluating the space. For me, it doesn't have the safety in general of trabecular meshwork canal. It may be lower pressure more, but there's also a fair amount of wound healing in this space. So I think there's a lot of questions still that exist. So for me, I don't do really any routine supracillular, suprachoroidal procedures myself. I do trabecular meshwork procedures, and I will group them as stenting. And I don't think there's one preference or the other. I think Hydrus and iStent both have their advantages. The Hydrus is longer, may have some more pressure lowering. The iStent can be more versatile and place it in different places if you do this. And I think both of the procedures work well with cataract surgery. I do think that in the developing world, however, that these are not available options. And I think that's why I think GAT or suture trabeculotomy, as Japanese have reported as well, using a simple 5-well-Prolene suture can be done around the world. And I encourage folks to consider this procedure because it can be, I don't want to say cost effective, but it can certainly be low cost. And it's a reasonable option that has been shown in published literature to lower pressure. It's not perfect. Patients don't always get enough lowering, but it is generally a fairly safe procedure that can be used in the right patient. And I think that's what we still have to continue to do. So I think I'm going to say provocatively, I believe every glaucoma specialist should have some mixed procedures, even if it's suture trabeculotomy in their pocket, to use in some cases, not everybody. And I think I mentioned earlier the cases that I typically use it in. And I think that it has a role there. And we have to have more data, of course, to support longer term benefits.
Thank you. Thank you very much.
Thank you, Dr. Aik.
Now, can I request Professor Zakia Sultana Shahid for your comment, please, and any question? Dr. Zakia, are you here?
Dr. Nazrul, I have one question for Dr.
Actually, coming to you, yes, Professor Tanuj, what is your experience about mix and your question?
No, I think GAT is the only procedure currently we can do and with the suture. But I was reading, I would like to ask Ike reports of late hyphema after GAT. So there's a patient gets up with spontaneous hyphema in the morning, many months and years after GAT. So that was something which I found quite scary. So your comments on that, Ike?
Yeah, I mean, there have been some reports. It's certainly not very common, but of course, physiologically, when you think about it, it may occur in some of these patients. We've had a few cases over the last 15 years. That is one benefit from stenting. Stenting, typically, we don't see that much blood reflux, but again, not available. But with ambulatory trabeculotomy, like GAT, for example, yes, there have been some reports of this. In general, it's small hyphema that may occur. It's rare to see a really large hyphema. And what I have done in those cases, sometimes you treat them with some steroids, but I can basically go and do some laser, typically a photocoagulation laser to the area where I believe the bleeding is coming from. And that typically resolves the problem in those cases. Again, I've only had a small amount, but yes, it is a known reported risk of this. Considering all the possible risks, though, I think it's very, very low.
Okay, thank you.
Now, can I request Professor Zakia Sultana Shahid for your comment on Dr. Aik's topic?
Thank you, Professor Nazrul. And many thanks to Professor Aik for his most wonderful presentation. We really enjoyed each and every moment of his presentation. The thing is that in the long reign of trabeculectomy, the MIGS showed
Maybe he's getting network problem. So I had a question to Dr. Tanuj. I know that you are very fond of trabecular filtration surgery, I know it. But are you doing any kind of mixed procedure in your practice, in your hospital?
So I have tried this GAT procedure.
Yeah.
And now we also have availability of micropulse laser. So that we are currently evaluating.
Okay.
So these are the two modalities currently we have. We don't have other type of this iStent or Hydrus or Zen is currently not available in India.
Okay. In Hyderabad, last year I went there, they are using the Kahuk dual blade in a limited scale because they said it is available. They bring it from outside. So you're not doing KDB.
Yeah, so we have we got recently trabectome is also now available in India.
Mm-hmm.
But if you see the literature on trabectome, the IOP lowering is not very impressive. So I am really not convinced about these procedures because we are getting patients at a very advanced stage, moderate to advanced glaucoma.
Yes.
And you have one chance with them. So that is why I think we are doing more of trabeculectomy. These procedures like the Kahuk dual bait or the trabectome, they are for a mild glaucoma or an early stage glaucoma. So I think currently we are still sticking with trabeculectomy, but I would like Ike's opinion on trabectome because I was reading the Mayo Clinic results with trabectome. It's not at all impressive. The target IOP is not at all coming below 18.
Mm-hmm.
Yeah, so I think that you're absolutely right. It depends on the patient profile. If your practice has all advanced patients, everybody is advanced, then I don't think you're going to have a big role for MIGS. Maybe for cataract surgery in someone with advanced diseases on 4 medications who you don't want to do trabeculectomy on, then maybe you do phaco MIGS to reduce medication. But otherwise, you're not going to have a big role for it. But that's probably what you've hit on is one of the biggest problems we have is we cannot compare MIGS with trabeculectomy. It's just not really a comparison that's really appropriate because there's different patient population, right? And advanced patient population is not. You may be interested to know most of my surgeries I do, if I do 100 surgeries, I would probably say 80% are bleb procedures, blebs, trabeculectomy, tubes, and PreserFlow or Zen. The reason is because my patient population is more advanced. Like you, I get patients who are, it feels like this. I cannot do a mixed procedure.
Yeah.
But there is patients who come, like I said, patients who's juvenile glaucoma, patients who have mild to moderate disease with a pressure of 25 and they can't take medications. I don't want to do a bleb for that patient. And that's why I think that doing a mixed procedure before doing trabeculectomy is where I look at it. So I think it's all about patient selection. We have more work to do to figure this out. With trabectome specifically, I think there's a lot of literature on this. The old studies showed, reasonable success. I would say in general, if you look at it, the pressures, are modest in what they can lower. And there's some differences between different centers. But I think, like anything else, I think it's probably dependent on how much you cut and how well you do it. And I would say that it does seem to lower pressure based on the literature. I don't do a lot of trabeculectomy myself, but from what I've seen from the literature.
Thank you. Dr. Zakia, can you listen to us? Dr. Zakia, please unmute and if you want to talk. Dr. Zakia, I think her internet is very much unstable.
Yes,
yeah,
exactly. My internet is
Okay,
very
then
unstable.
quick comment, please.
I was okay. I was telling that in the long reign of trabeculectomy, MIGS showed a quite remarkable revelation, and this MIGS became very much popular in Western world due to easy and high safety margin, less tissue damage. Can be we use it with cataract surgery for all this reason, but still that MIGS is not getting popularized in our country. I think that two things are remarkable that for why it is not getting popular in Bangladesh. One is cost and another is proper training. So I can ask Bangladesh Glaucoma Society to make it, how can we use MIGS in our country in a cost-effective way? And I can I request Professor Aik that whether he can help us with training of glaucoma people in how to do MIGS. That will be helpful for us.
Comment from
yeah. I think you're right. Like anything else, this is a matter of access, patient selection, and then training, right? And this is not easy. Even I can't say that that patient selection we know fully. I think the access is a challenge for cost, but like I said, I think that using suture trabeculotomy is a good approach, like GAT. And training, yeah, this is all about training. And now we have model eyes, we have artificial eyes, and I encourage all of you who are doing cataract surgery, get a gonio lens at the end of your phaco. You finish the phaco, turn the head, turn the microscope, place maybe your cannula in the anterior chamber just to practice, and view the angle. That's all you need to do. View the angle. Do it 10 times, 20 times, because your biggest learning curve is going to be not in doing the cut or the goniotomy. It's going to be the view and the visualization. And that's the biggest thing. It's just like learning gonioscopy in the office. When I have my residents come, they're pushing on the eye, right? They can't view the angle with the gonio lens. In the OR, you're going to find the same problem when you do intraoperative gonioscopy. You're going to push the eye. You're going to manipulate the eye. It's going to be difficult. And that's the challenge. And I will also say something provocatively. Most ophthalmologists don't do gonioscopy. I'm sorry to say this. In Canada, too. And if you don't do gonioscopy, forget MIGS. Forget it. Forget it.
Yeah.
Because if you can't view the angle in the office and don't know what to look for, you can't do MIGS. So we need to learn gonioscopy. That's probably the biggest pearl in this whole session, is actually gonioscopy. I'm sure Tanuja will agree as well.
Exactly.
Oh, yeah, agree.
Thank you. I think after this, everybody will try gonioscopy and trying to see the angle operatively. Thank you very much. We'll start the third speaker. Dr. Shelbin, one question to you. You are also working with MIGS. What do you think for Bangladesh, India, for the developing country, which procedure may be really helpful for us? What is your opinion regarding MIGS?
Well, I mean, I think a cost effectiveness would be a major consideration in a developing country. And certainly that would rule out a lot of the stenting procedures, such as the eye stent or the hydras, especially at the cost that they are currently pricing it as. So I'm hopeful that in the future, perhaps they could explore newer commercialization models and pricing models, such that they might reduce the cost of these devices in the hope that you increase the sales volume, and that may actually chart a more profitable path. But at this moment, I think that's still not possible. So in the absence of that, I agree with Ike that perhaps the most practical and most cost-effective ways would just be to use the suture to do a GAT procedure. I got one question for Ike though. What do you think of in the context of a failed trabeculectomy, if a patient wants to avoid another trabeculectomy or tube implant surgery, do you think MIGS has a role in that? For example, the trabecular bypass procedures, and what's your experience with that?
So I would say my first inclination is that I don't think it has a big role, because number one, I think that the pressure lower, if the patient needs trabeculectomy before, they probably need low pressure, right? That's why you did it in the first place. And so to do MIGS after, theoretically, maybe we don't get that low. That's the first point. Second point is that we wonder whether the canal is still useful. I can tell you that I've been proven wrong in that I have found in patients with previous trabeculectomy where the patient absolutely refused to do a tube or another trab or even needling, I was forced to do abdominal suture trabeculotomy. And although I have only a few patients, some of these patients actually responded well. They're still on medications, mind you, but they went from 24 with a failed trab down to 13 or 14 on medications. I guess that's relatively a success. So I do think that there probably is a role, although again, my inclination was questionable. And this probably has to do with the fact that there's still some filtration still occurring in the trabeculectomy and that you still have a functional outflow system despite doing trabeculectomy. So although it wouldn't be my first choice, I think that we have to explore this more, and there is some data on this. That's what I felt, that you can possibly look at it. That's my impression. I don't know about you.
Yeah,
Thank you. Thank you, Greg. We have many more questions. I will come after third presentation. Let me go to the third presentation now. Our third speaker is Professor Dr. Shelvin Singh. She is also a very talented ophthalmologist and glaucoma specialist working in the National University Hospital in Singapore. She graduated from Cambridge University with triple first-class honors, completed her glaucoma fellowship at Moorfields Eye Hospital. She has a special interest in the use of glaucoma drainage device. She is amongst the first surgeons in Asia to be accredited in the use of several novel MIGS devices. She is the co-inventor of the Paul glaucoma implant. Probably she's going to show us tonight. She is the adjunct clinical investigator of the Singapore Eye Research Institute. And she's also convener of the APGS MIGS interest group. And she has done few workshops on this and created interest to the participants on MIGS. And it is Shelvin with her family, friends. And over to you, Dr. Shelvin.
Well, thank you very much, Professor Islam, for this kind introduction. Just let me share my screen. And can you see my screen over there?
Not yet.
Not yet? Okay.
Are you clicking on the shared screen icon below?
Yes, I tried it. Let's see. Okay, let's try again. Let's share. Can you see it now?
Yes, yes, coming.
Yes.
Okay.
Yes, now it is coming.
Now it's coming, yeah.
Okay, so thank you very much, Professor Islam, for this kind introduction and for this invitation to speak. And I'm indeed very honored to participate in this webinar in such distinguished company. So I've altered the title of my talk slightly so that it doesn't sort of overlap with the other speakers' talks. And I'll be speaking on tube implant surgery, the veterans and the newbies. These are my financial disclosures, including patent rights to the Paul glaucoma implant. Before the recent excitement with the MIGS devices, one of the first few glaucoma devices available to patients were the tube implants. Unlike the subconjunctival MIGS devices, such as the Zen or the microshunt, a very distinctive feature of the tube implant is that it has a plate attached to it. So ironically, it's the plate that is the defining characteristic of a tube implant. And a capsule forms around this plate around 4 to 6 weeks after implantation. And the properties of this capsule will determine and regulate the flow through the tube eventually. Tubes are primarily used for patients with failed trabeculectomy and previous conjunctival surgery, secondary glaucomas, as well as those with a vitreous in the anterior chamber. In the tube versus trap study, in the context of a failed trabeculectomy, it showed that a tube had a higher success rate compared to traps with mitomycin C, as well as a lower incidence of additional glaucoma surgery. Tubes can be broadly divided into the non-valved without a flow restrictor, such as the bar valve and the Molteno, and the valved implant with a flow restrictor, and that is the armored tube. So the armored tube valve is pre-tensioned to open if the IOP is between 8 to 12 millimeters of mercury, hence protecting against hypotony. The surgical implantation procedure of the armored tube is not difficult. Just perform a 3 clock hour conjunctival peritomy. Prime the tube so as to prevent the valve leaflets from fusing together. Insert the plate underneath the tenons, and then suture the plate to the sclera. While in Caucasian eyes, it's possible to suture the plate about 11 to 12 millimeters posterior to the limbus, but the Asian eye and orbit is tighter and smaller. So therefore, I suture the plate about 8.5 to 9 millimeters posterior to the limbus. Make sure that you take a good bite of the sclera so as to prevent the armored tube from migrating anteriorly after the surgery. Fill the eye with a dispersive viscoelastic, and I usually use viscoat for this purpose. Bevel the tube as much as possible to minimize the risk of subsequent occlusion with iris postoperatively. Insert the tube into the anterior chamber, and I covered it with tutupatch, but you can also use tutuplast or even fasciolata or donor sclera. But the efficacy of the armored tube is limited by the small plate and also by the valve. So in patients with very advanced glaucoma, I would prefer to use the barbell tube. The barbell tube has a very large plate, so you will need to sling the muscles to insert the plate underneath the muscles. It's a non-valved implant, so it will require additional modifications so as to prevent early postoperative hypotony and have some flow restriction. I usually prefer to put a suture within the tube, and in this eye, I use a 3/0 supramid suture. I prefer to see no flow at the end of surgery, and this may require nylon ligating sutures around the tube to further occlude the flow. You may place more than one nylon ligating sutures around the tube so that if these are sequentially laser suturized after the surgery, it will result in a stepwise increase in flow through the tube. Check again that there's no flow and subsequently close the conjunctiva. The post-operative management of the barbell tube can be difficult because for the armored, there's immediate flow. So if the IOP subsequently becomes high, you simply add on glaucoma eye drops. But for the barbell tube in which there's early flow restriction, if the IOP is high despite maximum medical management in the early post-operative period, you need to balance between the risk of hypotony and the risk of the raised IOP. So the timing of interventions is very critical, such as lasering the suture around the tube or removal of the internal suture. If it's performed too early before a nice capsule has formed around the plate, then you will encounter hypotony. But if it's performed too late, then the raised IOP may result in irreversible glaucoma progression. This study compared the armored and the barbell tube in more than 500 eyes and showed that the barbell tube resulted in a lower mean IOP with a lower number of medications, as well as a higher 5-year success rate. However, the incidence of hypotony is significantly higher for the barbell compared to the armored. I usually choose the barbell over the armored in eyes which require a lower target IOP and have advanced glaucoma, or if they have a very aggressive scarring tendency. But this must be balanced against the complications of tube implantation, including hypotony, cornea decompensation, hyphema, tube occlusion, and exposure. Hypotony occurs more frequently after barbell tube implantation compared to after armored tube implantation. And if hypotony is persistent, my preference is to insert a suture up the tube ab internal without opening up the conjunctiva. I'd like to credit Dr. Keith Barton for this video on the left. And when I was working at Morpheus Eye Hospital, we used a 3/0 supramid for this purpose. The supramid suture is a braided suture, so it is stiff when dry, but soft when wet. So you have to be fairly quick when inserting the suture up the tube. Now that I'm working in Singapore at the National University Hospital, I do not have access to the 3/0 supramid. So I use a 3/0 Prolene for this purpose, and it works equally well. Ensure that the length of the suture is at least 10 millimeters so as to prevent the suture from falling out of the tube subsequently. However, occasionally, in a patient with a very high tendency or hypotony, you may choose to open up the conjunctiva so that after inserting the suture in the tube, you can have additional ligating sutures around the tube as a safety measure. In such eyes, the patient often goes back on maximal glaucoma medications. Corneal decompensation is another complication of tube surgery. And if the tube is anteriorly positioned, you may need to reposition it subsequently. Make a needle track posterior to the initial entry site of the tube. And I usually prefer that the tube is resting flush on the iris. An important step is to plug up the initial tube track with like a tutu patch so as to prevent early post-operative hypotony before closing up the conjunctiva. Now, my usual practice is to ensure that the tube is in a good position with intraoperative gonioscopy before ending the surgery. And this video shows the ideal location of the tube through the sclerospur. If the tube enters the eye posterior to the sclerospur, for example, through the iris root or through the ciliary body, it's good in a way that the tube is far away from the cornea, but this can result in a higher incidence of post-operative bleeding and hyphema. I'm usually not too bothered by post-operative hyphema because it's usually self-resolving with no visual consequence. However, in this eye, some of the bleached blood entered the tube and occluded it and didn't resolve. So this required an additional surgery to perform anterior chamber washout as well as flushing of the tube. Tube exposure is another complication of tube surgery, and the reported rates range between 2 and 14%. In this eye, a corneal patch graft was used to patch up the exposed tube with a good long-term outcome. While the veteran tube implants have been available for several decades, in recent years, we now have a couple of new options, which are slight variations of the older versions of the tube. The armid clear path looks very much like a barbelt, and except that the suture holes have been moved anteriorly, improving access and therefore making it easier to suture the plate to the sclera. There's not much clinical data on the armid clear path, so for the rest of this talk, I'll focus on the Paul glaucoma implant. The Paul glaucoma implant, or the PGI for short, was invented at the National University Hospital in Singapore where I work. So I've been very privileged to be involved in the development of the device. It all started in 2012 and we have come a long way. From flow control studies in the laboratory, we then moved on to animal studies. And you can see the PGI in a New Zealand white rabbit eye. And the eye is very quiet, showing that the PGI is biocompatible and doesn't cause inflammation, and also worked well to reduce the IOP. So 2017 was a very eventful year for us when we filed for the US patent, started the first in-man study, and also attained the CE mark. And on the patent, the co-inventors were Paul Chu and myself from NUH, as well as Keith Barton from Morpheus Eye Hospital, and Eugene Kaur, who is our engineer collaborator. The plate surface area of the PGI is larger than the armid and more similar to the barbelt. Perhaps the most distinctive feature of the PGI is the small tube size. So while the armid and the barbelt tube internal lumen diameter is about 300 micrometers, the internal lumen diameter of the PGI tube is only about 120 micrometers. The implantation procedure of the PGI is very much like the barbell tube. Flush the tube with a 30 gauge needle. You would need to sling the muscles to place the plate underneath the muscles. Then suture the plate to the sclera. I would usually use an 8/0 nylon for this purpose, and I'll suture it about 8.5 to 9 millimeters posterior to the limbus. Ensure that the plate is well secured to the sclera before entering the eye with a 27 gauge needle. The tube should fit very snugly in this needle track without any peritube leak. Once the tube is well secured to the sclera, insert a 6/0 Prolene suture into the tube as a flow restrictor. I would push the Prolene all the way to the limbus, but not into the anterior chamber. With the Prolene in the tube, there should be a very slow trickle of fluid through the tube. And this usually brings the pressure to about 6 millimeters of mercury on post-op day 1. Suture the Prolene to the sclera, making it easier to locate it subsequently if you want to remove the suture. And finally, close up the conjunctiva. The Prolene suture can be very well seen underneath the conjunctiva of some patients, making it very easy to remove. And with just topical tetracaine, most patients are very comfortable to have the Prolene suture removed at the slit lamp. With Barnes scissors, dissect through the conjunctiva and the tenons all the way down to the sclera. And ensure that you're at the same plane as the suture so that you can remove it easily. You can now see the suture very clearly. And you can remove it with forceps. If the patient wants it, you can give it to the patient as a souvenir. But in some eyes with very thick tenons, such as in Asian eyes, it can be difficult to locate the Prolene suture underneath the conjunctiva. So in such eyes, I find it useful to use a Hoskin lens, which is, for example, the one that's used for laser suture lysis. And you can compress the conjunctiva and the tenons and just about make out the faint blue tinge of the Prolene suture. The 1-year outcomes of a multi-center case series of the PGI have recently been published in Ophthalmology Glaucoma. At 1 year, the PGI reduced the pressure from 23 pre-op to 13 post-op, and the number of medications from 3.3 pre-op to 0.3 post-op. So these results suggest that the efficacy of the PGI is more similar to the barbell tube because of a similar plate size and superior to the armored tube. The safety profile of the PGI is pretty good. It's similar to a barbell tube and the armored tube in most cases, but the most common complication post-operatively in this study was a shallow anterior chamber. So this occurred in up to 15% of the eyes in the study. And the PGI is a non-valved implant, so we require additional modifications to restrict flow in the early post-operative period. However, in the study, some of the investigators chose to put the PGI without any further flow restriction. So this resulted in these cases of shallow anterior chamber. However, with my technique of using a suture within the tube, I haven't encountered a case of a shallow anterior chamber. If the AC is too shallow, you may need to reform it at the slit lamp with viscoelastic. However, some cases also resolve spontaneously. In the study, comparing the complications of the PGI compared with the barbell, the results suggest that the incidence of persistent hypotony may be lower than the barbell at 1.4%. And this may be because the tube size is smaller as well. So in summary, barbell tubes are more effective in lowering the IOP compared with armored tubes, while associated with a higher rate of complications. Finally, after many years, we now have novel tubes with a similar plate size as the Barvelt, which therefore may achieve similar efficacy compared to Barvelt tubes, but may have a lower rate of complications. However, we do need further randomized controlled trials to verify this. Thank you very much for your attention, and I'd like to invite you to visit our APGS Mixed Interest Group website. Thank you.
Thank you, Dr. Shelvin Singh. Would you please stop share? Glaucoma devices actually, unlike mix, our doctors in Bangladesh, many of us are doing. We are practicing the Ahmed glaucoma valve mostly, but also RD, the Indian, I think Professor Tonus can say, RD is just like Barvelt. We are also using, which is very cheap, using in Bangladesh. And PGI, fortunately, I brought 5 pieces PGI from Singapore and I used it in Bangladesh. So we are not unlike mix regarding the devices we are using. Our doctors are using a bit in cases, especially in the refractory glaucoma cases. Thank you very much for your very nice presentation on different devices, especially the newer devices on Ahmed path and PGI. Thank you very much. Now, can I request our panelist, Professor Shekhar Mannaf, comment on this topic, please, sir.
Thank you very much, Nazrul. Thank you very much, Dr. Shelvin Singh, for your nice presentation. Although I don't have any experience on the GDD or mix, I am doing only trabeculectomy, what I said earlier. But still then, I would like to say, we should have to start the mix and GDD bulb surgery in Bangladesh. And if the bulbs, what are PGI is known in Singapore, if those are available in Bangladesh with a low cost, then it will be very easy to for us to use in Bangladeshi peoples.
Thank you, Professor Shekhar Mannaf. Any comment from Professor Arif? Professor Arif Mia, please unmute, please. Professor Arif Mia, unmute, please.
Hello.
Yes, please. Your comment,
Hello.
please. Your comment.
Thank you, Dr. Shelvin Singh, for your nice presentations regarding tube shunt operation in glaucoma. Really, if trap fails or in some conditions where it is resistant cases of glaucoma, we should do tube surgery. But really, in Bangladesh, recently, many of our ophthalmologists have started this nicely. We commonly use Ahmed glaucoma bulb, which is bulb device. But you have said that you prefer to do Barvelt bulb without bulb. I want to know why you choose this. If you are knowing that it has got more complications than Ahmed bulb, why you like this to do Barvelt? Or have inspired you to do this Barvelt bulb?
Professor Arif, I think that is told is not more complication, because there are many studies showed Barvelt is superior for controlling the IOP.
In the long run, for
the long run, Barvelt is superior.
Yes. But immediately a lot of
IOP, I think that is the reason.
Hypertony is more and more. Yeah.
This is only for in some cases, but in a long term, all study proved that Barvelt is superior to Ahmed. But Ahmed has less complication than Barvelt. That is true, if I'm not wrong. Dr. Shelvin, please answer your question.
Yes, so Professor, thank you very much for your question. I do agree that the Ahmed valve is safer compared to a Barvelt valve. So I think it also depends on the surgeon's expertise as well as comfort with using either of the devices. So if you do have a patient with very advanced glaucoma, you have to balance the safety of the risk of complications and losing vision from complications of surgery with the risk of losing vision from the glaucoma. So certainly in a patient with very advanced glaucoma, the risk of losing vision from glaucoma trumps losing vision from the surgical complications. And because of this, I'm able to take a more risky approach, but which is more effective in lowering the IOP. And I think some of the, perhaps some of the complications on the Barvelt tubes include hypotony. And though this is in the studies, this is considered a failure, but I do believe that this is an addressable cause and is something that we can certainly reverse, for example, by inserting a suture up the tube. So if it's managed appropriately, we can still prevent vision loss from these complications from the barbell tube surgery.
Thank you very much. Dr. Aik, you do both Ahmed and Barbelt. So this question has come. Ahmed has very good result post-operatively first few months, but why people are using more Barbelt in the Western countries?
Yeah, I mean, I think actually, if you look at the data in Western countries, at least in North America, I should say, maybe not Europe, but North America, Ahmed valves are used in a similar numbers as bare belts, 50-50 almost. In Europe, it's a little bit different. Other parts of the world, it's a little bit different. In South America, for example, Ahmeds are used more commonly. Sometimes the bare belt's not available. So a couple of things. Yeah, I mean, we have published some big studies, as Shelvin alluded to, including our pooled analysis, which did conclusively show that in 2 big randomized studies that bare belts lower pressures more than Ahmeds. My personal opinion is I think it's more related to the fact of stopping aqueous flow for 6 weeks, rather than really simply being just because of the plate size. That's my own personal opinion. I think there's something about aqueous when it reaches the capsule of a developing bleb around the plate that becomes more fibrovascular versus fibrodegenerative. But that's, whatever the reasons are. So I think that's clear. Complications and manipulations and interventions are certainly more involved with bare belt, although, I think with proper surgery that can sometimes be addressed. So I don't like to use Ahmeds in young patients or patients who have very advanced disease. I will say my bias is to do bare belt, honestly. But for many other patients who are older, neovascular glaucoma, pressure target is not so low, Ahmed I think is quite reasonable. But here's one tip that makes a difference. I believe so. And if you're not doing it, I think you should do it for an Ahmed. Is I aggressively treat pressure for the first 2 months and keep them on medications, because reducing flow into the Ahmed valve, I think, is better for the bleb to form. There's less tension on the capsule, there's less aqueous cytokines, and the bleb does not get as thick. And so I typically stop the medications on post-op day 0, but by post-op week 1, when the pressure is coming up, 12, 13, I will put them back on their medications, including Diamox, even for 2 months, to keep the pressure at 10, which is different than trabeculectomy. Trabeculectomy would never do this, but for Ahmeds, I do this, and I follow them up quite closely. If you do this, study from LA, study from Iran, our study, all 3 showed that we have less encapsulation and we have lower pressures with Ahmed than if we just treated normally without adding medication unless the pressure was high. So I really push hard to keep the pressure at 10 or 12 for the first 2 months. I know it sounds maybe for some of you a bit unusual, but I can tell you that makes a big difference. And it's not like a trabeculectomy where you lose the bleb. It's no problem.
Thank you very much. I think you also do in refractory glaucoma cases the devices. What is your choice and why?
No, I think what Ike has pointed out is a very vital thing. You have to have a low pressure and a quiet eye, because if you have inflammatory aqueous, you end up with very bad capsule formation with the MS glaucoma valve, and that is very difficult to treat. Once you get that capsule, nothing works. So my suggestion is that if you have a very huge glaucoma practice and you're doing a lot of drainage devices, then you should go for barbell. If you are an occasional surgeon and you're doing very few cases, like once a month or once in 2 months, then go with the Ahmed, because you are concerned with less complications. And if you see the Ahmed versus barbell study, the rate of phthisis bulbi is 6% in the barbell implant. So that is, to me, quite unacceptable. So if you are not very confident in managing hypotony with these sutures, and then stick to Ahmed valve. Second issue is, I think the main problem with the valves is the corneal endothelium. So for people who are starting valves and who want to do, I would suggest start with pseudophakic eyes, because if you do a valve in a phakic eye, over time there is very high risk of corneal endothelial decompensation. So try to select pseudophakic eyes, and you can also try to put it in the ciliary sulcus below the iris. So that is a safe area which prevents endothelial cell loss. So that is my few words on. And I have one question for Dr. Chelvin.
Yes.
There's some issue regarding whether you need to put a scleral graft or you can use these implants without a scleral patch graft and just use an intrascleral dissection. So any comments from you on Ike on that? Because many places the scleral patch is not available.
Yes. So thank you very much, Professor Tanuj, for your question. And certainly, I think it's possible to use a large scleral flap to cover the tube rather than to use a patch graft, because that's certainly much cheaper. I mean, for us, we do use the patch graft as well, because on top of the patch, besides using a patch graft, I also make a small scleral tunnel so that I put the tube in it and I suture it tightly to this tunnel to reduce the profile of the tube and hopefully reduce exposure, and also to prevent micro movements of the tube so as to prevent any exposure. So that's why I prefer to do that and then to put a patch on top of it. But certainly, I think that if you do to dissect a scleral flap, that's also an acceptable way of covering the tube.
Thank you.
Yeah, I agree. I would say that even a graft alone may not be enough, because when the tube is on top of the sclera, then it lifts up the graft and the conjunctiva and it forms a bump, and this can be a source of erosion. So I like the idea, as Chelvin said, even if you use a graft, make a scleral tunnel. I mean, go back 3 millimeters and make a tunnel to enter, and then put a graft on top if you want. Now, Felix Hill from Mexico City reported hundreds of eyes of using just only scleral tunnel, a 3.5 millimeter scleral tunnel, and has a very low erosion rate. So I think we've been doing a lot of tunnels. I think they're probably similar in terms of erosion rates compared to cornea or scleral grafts. But I think what's most important is, again, how you enter and the angle you enter and everything else. So I think it's not unreasonable to consider it.
Sorry, I think I have to clarify that when I said the tunnel, I made a little groove, so I dissected a piece of sclera out. I think it's definitely nice to put a tunnel as to go in with a needle and then angulate it in, but I do find it harder to get the tube at a very nice angulation flush on the iris with a tunnel, and that's why I prefer to make a groove and then enter in with a needle.
So I think you're right. The longer the tunnel, the more it's going to be hard to get into the anterior chamber, right? Yeah. And I think you do stand up more. So you're removing a block of sclera, right? Like
yes, I'm doing. Yes, absolutely. So I'm removing a groove, and so as to lower the profile of the tube, and hopefully that might reduce any erosion.
Thank you. In our country, actually, donor sclera is not available. So most of our cases, we use the patient's scleral flap. And personally, I use the term short tunnel, short flap. I make 4 millimeter tunnel. Then under a 4 millimeter flap, I put my tube. I cover my tube. Usually I do that in that way. It is economical. We don't have to purchase the donor. Dr. Istiak and Dr. Salma, do you have any question? Dr. Salma, please.
Thank you, sir. I have just a comment, madam,
yes.
To Dr. Selvin Singh. Madam, how this advanced technology give more hope to glaucoma patients? What do you think, madam?
Well, I certainly think that all these new developments are giving hope to glaucoma patients. From 20 years ago, when we only have two options for treatment for glaucoma patients, which is medications or trabeculectomy, now we have various implants as well as new mixed devices as well. So we can cater the treatment more specifically for patients with different severity of glaucoma, from the very mild to the very advanced glaucoma. And we can look at other measures of success other than just IOP and disease control, but also their quality of life.
Thank you, madam. The thing is that for the financial barrier, we cannot adopt all these actually advanced devices. So that is our main challenge and barrier to us to this type of developments like Bangladesh. Oh, thank you, madam, for your good presentation.
Dr. Stiak, do you have any comment?
I have two questions to Professor Ike. Is that yes. What is there a cutting limit of IOP that you would go for trabeculectomy and not mix? And what is the experience that that you have put mixed and then you had to convert to I mean later on do trap?
Yeah, great point. Maybe I'll answer your second question, Istiak, and keep on doing the good work you're doing as well. So I think that the one benefit of doing mixed procedures is we don't touch the conjunctiva, and I think this is a benefit where we feel, and I think my experience has been that the success rate of doing trabeculectomy or filtering surgery is really minimally altered by doing a MIGS procedure. Just like clear cornea phaco, it's a similar like phenomena, although there's less blood aqueous disruption even. So I think that we can feel comfortable that this is a procedure that can still leave the door open to doing a more aggressive procedure, which patients often do require down the road. So I think that's the first point. However, there's one small point, which is when you do trabeculectomy, if you get hypotony, sometimes, as Tanuj mentioned earlier, you get reflux bleeding from the goniotomy that's done. And it's a bit perplexing because the pressure is high, the goniotomy didn't work, and now you do trabeculectomy and pressure is lower, and then you get some hyphema from it. Again, this is usually short-lived, it's temporary, but it is one small thing to kind of think about when you have that. Again, if you do a large trabeculotomy. As far as your first question, yeah, I mean, if I need a patient's pressure, and if patient's progressing with pressure in the low teens, and they're compliant, normal pressure glaucoma, that patient in my hands is typically getting trabeculectomy. Maybe I'm doing some other devices like PreserFlow with mitomycin. I'm getting pressures that may be closer to it, but still trabeculectomy is the king, mostly because you can titrate the pressure lower with suture lysis or releasable sutures, and you can needle easier than with another procedure. And so I do like trabeculectomy in those cases, and that's where I do it. And the last thing I'll mention is I am very much a revision surgeon, so I like to revise my surgeries. Unfortunately, with MIGS, you can't really revise MIGS, but with trabeculectomy and even tube shunts and subconjunctival MIGS procedures, if the pressures are high, either I needle or I take them back to the operating room and I open up the conjunctiva, I excise the scar tissue, I'll put mitomycin 0.5 milligrams per cc, and in this case, I sometimes use Ologen, and I put the mitomycin in the Ologen. And I agree with Tanuj, I don't use Ologen routinely, I don't. But in the reoperations, I think maybe I do it and I put mitomycin in the Ologen and I do a heavy dose. And I do like to revise surgery a lot. So that's kind of what I would say with how I do my procedures.
Thank you. Dr. Salma, any question from our audience, from the participants? Dr. Rashid Nizam is here. Dr. Rashid Nizam, if he's here, he can come to any comment.
Yeah, he is in the panel. He is in the panel.
In the panel, please unmute and open your video, please. Dr. Rashid Nizam from USA. Maybe he can, because he's muted. Okay, any question important? No, not.
Oh,
there he is. Yes, Dr. Rashid Nizam.
Welcome.
Yeah, assalamu alaikum to everybody. Mashallah, it's very nice, and thank you. I can all of us to come and give your invaluable, the comments and experiences sharing with all of us. That's been very nice. Actually, I rather to listen to the, them rather asking and then, wasting time. So it's very good. I'm thankful to all the panelists and wonderful job for arranging such a very educational webinar. Thank you. I congratulate all of you, the people arranging and working hard. Thank you.
Came to Bangladesh and you trained many of us on Kahuk dual blade and eye stent. Thank you very much, sir, for that. Thank you. If you have any comment, please, for the...
Yeah, we're trying to do that. Inshallah, the one thing maybe I can also, I'm trying to new medic to see if we can lower the price for Kahuk dual blade. That's the one thing will be least expensive way if they want to do that. So they try to train them, and I'm working on that. They said they will do their best to lower the price for Bangladesh and the developing countries so that it can make more popular. For business sense, it makes sense for them too. So working on that, I'll update you, inshallah.
That's great, inshallah. New World has been so amazing with sharing and getting access. So we thank them, alhamdulillah. They're such a good company to work with.
So I have some question. If you give me 5 minutes time, sent by our participants previously. Can I share my screen? A few questions here.
I'll just make one quick comment, Nazar, before I forget, is that we cannot forget one most important point.
Yes.
Which I think was mentioned, but preoperative optimization is so important in my opinion. Yes. I go around the world, I see people operate, and I go to the operating theater, and the eye is red, and the eye looks terrible. I refuse to operate on trabeculectomy or bleb procedures unless I treat the blepharitis, the ocular surface. I will stop the drops and put them on Diamox, acetazolamide, and I pre-treat with steroids. I want the eye to be quiet. I will even tolerate pressure to be a little bit high for maybe 2 weeks before doing surgery, because operating on a hot eye and all the drops cause problems. You know this. It's just a recipe for problems after surgery. So I really, really plead that we need to do this. There's some data to support this in studies, but really do this. Pre-treating with steroids should be universal, in my opinion, for at least 1 week for these patients.
Thank you, Dr. Aik. This is a question sent by one of our attendee that this patient had 2 Barvelt and also the tube erosion, the exposure of the tube, and how to manage this case. Any speaker panelist?
Okay, I can take that one.
Yes,
so
sure.
this is a patient have I can see 1 Barvelt tube. You said he had 2 Barvelt tubes?
Another one. There's another one.
Oh, okay. So one is exposed, but the other one is okay. So I think it's quite common in a patient with scarred conjunctiva to they are at higher risk of having tube exposure. This is because the conjunctiva is very tight over the tube, and it can lead to eroding of the conjunctiva over the tube. So for these cases, first of all, I usually try and reposition the tube. So if I would avoid the area of the tube exposure and the unhealthy conjunctiva. I will excise that. I will try to curve the tube maybe more superiorly, in which there's some area of healthy conjunctiva. And also when closing up, I'll try to leave it when there's a lot of tension closing up. You might want to use a conjunctival graft from another part of the eye to close up the tube so that there's no tension over the conjunctiva that is overlying the tube, and it will have a lower chance of exposure. But in some eyes in which there's a very high risk or have multiple tube exposures, you may want to do a cornea patch graft like I showed in my talk, and those usually last quite well and quite long.
Thank you. So we'll have to cover the conjunctival graft because this is a scarred area. This scarred area is the right eye, so it has no place here to put. So will you take any conjunctival graft over it?
Yes, but I would shift the tube. I wouldn't use that same area because that shows that the tube profile is not good in that area. So I'll shift it maybe a little bit to an area with a healthier conjunctiva. I'll make a scleral groove as well. Make sure I reduce the profile of the tube. Make sure the tube is well anchored to the sclera to prevent any micro movements of the tube.
Thank you.
Yes.
Thank you. This is another question for Dr. Tanuj Dada. You can do a block dissection or by Kelly's pass. Which one is used and what is the advantage?
No, I think it depends on what you are comfortable with.
Okay.
If you have a good Kelly's punch with it sharp and you can do a dissection, please go ahead.
Okay. Okay. It's personal experience.
One question from the audience that is to Dr. Tanuj Dada.
Yes.
Sir, what is your opinion about the single suture trabeculectomy? This question from one of the participants.
In your cases, you have shown nicely releasable suture, adjustable suture, and some way. Some person are also doing only one suture.
Single suture.
Suture. What is your comment on that?
See, one suture, if you have a very good architecture, you can use one suture, but I would say there is no additional advantage of using one suture because in a trabeculectomy, you want to titrate the filtration. So if you have only one suture and supposing that suture is tight, then in the post-operative period, how you will adjust and how will you do laser suture lysis because you only have one suture. And secondly, you are making a rectangular or a square shaped flap. So minimum, I think you should use 2 sutures, and if possible, use additional releasable or adjustable sutures so that you can titrate the IOP in the post-operative period. So although you can do one suture, but I would not be in great favor of it because you can't do any adjustment post-operatively.
Yes, yes.
Thank you. Dr. Aik, this is for you. This question is for you. That this patient, 62-year patient, had 3 barbelt in the left eye, supranasal, all the 3 corner except nasal. And the patient IOP is 33 with MMT. and patient vision is good, 624 with the cataract. So what is your plan of management in this patient?
Yeah, I mean, that's a lot of tube, man, in an eye. And I would say that I'm not sure I would have done a third one after the second one failed. And even after one tube failed, if it's a bare belt, I'm often reluctant to just go do the same thing. That's the first point, although I understand the challenge here.
This patient had trabeculectomy also. See, this patient had failed trabeculectomy also.
Trabeculectomy as well. I see that. Yeah, I see that. I think I want to understand a bit more why this patient has failed 3 bare belts. This is a bit strange. And either this patient has some really bad ocular surface issues or inflammatory problems, or maybe they have a tight orbit. Now, we don't talk about the tight orbit very much, but if you have a tight orbit, then that can really inhibit, bleb formation posteriorly. If that's the case, then I think any tube is not going to be functional enough. Obviously, in this case, I would be thinking about whether I need to now do something more on the cycloablative side. In my hands, I would probably do cataract surgery if there's a cataract, and I have access to the endoscopic cyclophotocoagulation, which I can use to more carefully titrate the ablation of the ciliary body. You've talked about micropulse or slow coagulation, G-probe techniques, which I think are useful as well. And I will say that is an option. Although in my hands, I would probably try at least one more time. And I would typically do in my hands a PreserFlow device, which I feel comfortable placing inferiorly. This is a subcons mixed procedure, and I would use lots of mitomycin, and I would use Ologen soaked with mitomycin, and I would do postoperative 5FU injections as much as I need to. And I feel comfortable doing that inferiorly, because superiorly you have no more access to it.
Yes.
To do this. So that's what I would say. But there is something you need to understand. Why is this patient failing? Are they inflammatory? Are they ocular surface? Are there orbital causes? Something doesn't seem right here, that their pressure is so high and they're on 4 surgeries and bare belt. Something's unusual. I would refer the patient to Singapore or to Delhi.
To Dr. Shelvin. Okay, Dr. Shelvin, what is your opinion? What do you do? Dr. Ike has given management. What is your management?
Well, I would say I agree with Ike that it's very unusual for someone to fill 3 Barvelt tubes. Barvelt does usually quite well. Yes. I think I wouldn't put another tube in.
This patient was operated in Singapore. This patient was in Singapore, yeah. Okay.
So I'll also evaluate, I think the cataract, if the cataract is causing visual impairment, you might want to take the cataract out. But if it's only early cataract, then perhaps that wouldn't really solve the problem of the vision. Then that's due to glaucoma. I don't think there's space for any more tubes. I don't think a 4th tube is going to be more successful than 3 tubes. I might consider revising the capsule around the tube plate, such as performing a tenonectomy, tenon's excision of the capsule around the tube plate. And then subsequently, I'll put the patient on more aggressive steroids as well to prevent scarring, to make sure that when the capsule reforms, it doesn't reform to such a thick extent.
Thank you. Last question for you.
I have a question to Dr. Tanuj Dada.
Dr. Shelvin, is a good question from myself, because I have used for PGI, but I have in some cases ripcord. Here you can see, but in some cases I have given the suture, 6-0 Vicryl suture. So what is your opinion? Which one is best? And in any cases, I have not given any occlusion suture in the ripcord, but here I have not used any ripcord, rather suture. So which procedure do you feel better?
Well, I think there are pros and cons of each. With the ripcord, you're meaning that you occlude the flow completely, isn't it? So as Professor Ahmed have said, when you occlude the flow completely, it prevents the inflammatory aqueous from getting to the bleb, and therefore may have a better bleb formation around the plate of the tube. However, when the suture lyses, there's no control. It can suddenly go from high pressures to hypotony. You don't really have control about the timing of the suture lysing. And I prefer to put suture down the tube. Well, I find that with a 6-0 Prolene, you get a very predictable pressure of about 5 to 6 millimeters of mercury on post-op day 1. And usually if you subsequently, the pressure goes up. If you remove the suture, I also get quite a predictable decrease in pressure by about 5 to 6 millimeters of mercury. So in this way, I can prevent hypotony. So if the pressure is 12, I wouldn't take the suture out. But if the pressure is like 14 or 15, I might take the suture out. So there was one case in our case series which had persistent hypotony. It's quite rare with the PGI, but still occasionally it can happen. And that's with a ripcord when there's immediate flow. So I guess that if you wanted to avoid that, you would rather put a suture within the tube. Or you can have both. You can have a suture in and tie it off as well.
This discussion is so excellent that I have forgotten my time. I'm sorry for that. Already we overshooted. Thank you so much, all the speakers. I think last question, last comment from any panelist, any moderator.
I have a question to Dr. Tanuj Dada.
Quick question.
Before coming to the webinar, I have seen lots of his videos of trabeculectomy in YouTube, and have seen that in almost in every cases he used rectangular flap. Aren't you go for triangular? Why do you prefer this rectangular rather than triangular?
No, see, if you are comfortable, you can go for triangular. The only issue is that when you make a triangular flap, it is tapering. So if you make the ostium, that can come very close to the edge of the triangle, and you can have leakage. Second issue is, if you just tie one suture and it is tight, you can get a lot of astigmatism with a single suture in the triangular flap. Otherwise, if you are good in the anatomy and you don't overlap the edges, you can go ahead and do a triangular flap also, no issues.
Okay, thank you.
Sir, one question to you, Dr. Tanuj Dada, sir. Do you practice MMC under the spiral flap?
So,
one question from the audience.
Yeah, I answered that on the message itself.
Presentation.
So ideally, most of the cases we use subconjunctival. For neovascular glaucoma and some congenital glaucoma where there is high risk of repeat surgery, I will put 1 minute under the scleral flap also, but not as a routine.
Okay, thank you, sir.
Thank you.
I have a question to the honorable speakers.
But time is already going.
One question.
Last question, please. Last question.
Can you, honorable speakers, can we have the hope of light that gene therapy and stem cell therapy for optic nerve glaucoma optic nerve atrophy, and gene therapy for trabecular sclerosis in case of POG? Have you got any hope for curing this by stem cell therapy or by gene therapy? Your opinion regarding this gene therapy and stem cell therapy?
Sir, I don't think stem cell therapy, there's a lot of research, but clinically it has not been successful for glaucoma because the long synapse between the retinal ganglion cells and the occipital cortex. So it is still very experimental stage. Clinically, it is not proven stem cell therapy for glaucoma.
And gene therapy, any hope from gene therapy or trabecular measure?
I think we'll not go long. I think last comment from our senior glaucoma specialist, Professor Mannaf, then we'll conclude the session. Unmute, please. Unmute, please.
Thank you very much.
Quick comment.
Thank you to all the speakers, Professor Tanuj Dada, Professor Naik Ahmed, and Professor.
I'll say simply, really, we are grateful. Really, we are grateful to all the speakers. Professor Aik.
No, Nazrul.
Yes, sir.
Nazrul.
Okay, please continue.
One thing. There was one question to Aik Ahmed that he does not like to do combined surgery like phacotrap, but I am doing combined surgery since 1994. And but since we are doing ECC and trabeculectomy, then phaco and trabeculectomy, and we are doing phacotrabeculectomy, patient likes it because patient has to go once for both cataract and glaucoma. I want to know why Professor Aik does not like to go for the combined like phacotrap surgery.
I can answer quickly. I mean, I think that it's pretty conclusive with the studies, certainly on a basic science level, that when we do combined phacotrap, there's more inflammation and there's more blood aqueous disruption. The lens epithelial cell and blood aqueous disruption. And so the TRABs are more likely to be inflamed and more likely to require 5FU or needling. It's certainly done. I do them as well. Don't get me wrong. I think it's convenient for the patient. But in an ideal world, it does create more potential inflammation in the eye, which is not just for the first week. It actually lasts longer. The blood aqueous disruption after phaco is at least 3-4 months. It's not just for 1 month, and this affects the blebs. So that's why ideally, now, of course, practically it doesn't happen. The other second part is that phaco alone can lower pressure as well. And so depending on the target pressure, I like to try phaco first or phaco MIGS. And even if the success rate is low, I can then separate it out. Now, the reality is, of course, many patients cannot have 2 surgeries, or they cannot afford it, or whatever else. Of course, in those situations, you have to do it together, and you do phaco trab. And so I do the same thing. I do it together if I have to. But in an ideal world, if there's a shot to do it phaco or phaco MIGS, and I have a chance to do it, even if it's 50% success, even 30% success, phaco MIGS at reaching target pressure, that means I've been able to save a trabeculectomy in 1 patient out of 3. So this is my approach, but again, it's really customized. But I don't think there's a doubt in my mind. When you do cataract surgery, there is more inflammation in the eye, and there is more bleb issues. But mitomycin C fortunately saves us because it does address some of those issues. That's what I would say.
Okay, thank you very much.
Thank you very much. I think I will thank again all our speakers, Dr. Aik, Dr. Tanuz, and Dr. Shelvin. We want to see you in Bangladesh physically.
Sure.
That is our wish.
Over. Thank you very much. I thank all the panelists, Professor Mannaf, Professor Arif, and also Glaucoma Society President, Professor Mizan, and Secretary General, Dr. Salma, and Dr. Ishtiaq Anwar also here, and many people behind the screen was helping to hold the webinar, Dr. Ashraf, our Secretary of Science Scientific Committee, Dr. Ruhi Mannan, and the Aris Division who is hosting the webinar, especially Engineer Asif. All of you, really thank you so much, so much. Thank you so much. I personally grateful to all of you and want to see you again. Thank you very much.
Inshallah.
Thank you. Bye.
Thank you.
Thank you.
Thank you.
Thank you, sir.